Hi, this is Darcy Gaydon, and I am recording audio to the Diabetes Mellitus PowerPoint. Just a brief pathophys overview of the endocrine system before we start diabetes. We will be doing more detail of this once we get to the other endocrine portion of those disorders. But the starting point is really important to understand that the hypothalamus is basically our link between the nervous system and the endocrine system. The hypothalamus controls the release of the pituitary hormones. So the hypothalamus sends releasing hormones, and then the anterior pituitary releases the stimulating hormones to the actual organ or gland, where it then is told to make hormone or substance of that gland. For example, the hypothalamus will send releasing thyroid releasing hormone to the pituitary gland. The anterior pituitary gland will then send thyroid stimulating hormone to the thyroid gland to tell it to produce T3 and T4, which are our two main thyroid hormones. I like this picture also just so you can make note of where everything lies as far as the anatomy. So the hypothalamus up in our brain, and then the pituitary gland is also there, also called the hypophysis. So the pituitary is the master gland. It controls secretions of all of our hormones, and then therefore regulates all of the other organs and glands. The hypothalamus, of course, that's the structure in the central nervous system that is that link between the nervous system and the endocrine system. So that all starts in the hypothalamus. This controls release of the pituitary hormones. It sends the messages to the pituitary gland. Again, then to send stimulating hormones to the glands themselves. You can see where the thyroid and parathyroid are there on the anterior neck. And the adrenal glands that sit right on top of the kidneys. We'll be talking about disorders with that. And then here in the diabetes section, of course, the islets of Langerhans in the pancreas, the beta cells responsible for making and releasing insulin, and the alpha cells of the pancreas are responsible for releasing glucagon. Our body relies on our feedback mechanisms, kind of a check and balance type thing. And so the regulating mechanisms will either increase or decrease a level of the substance based on the function of what the organ is actually producing. So for example, a low blood glucose will stimulate the pancreas to secrete, the alpha cells of the pancreas, to secrete glucagon in order to raise that blood sugar. The opposite will be true if we have a high blood glucose. Our body, assuming we have a normal functioning beta cells of the pancreas, will produce more insulin in order to lower that. So this feedback mechanism ensures that we are keeping the right amount of levels of hormones. What causes endocrine disorders? Basically, we're going to either see a hyposecretion or hypofunction of the gland, or hyporesponsiveness, or we can see an hypersecretion or hyperfunction. So for example, hyposecretion is just insufficient supply of the hormone. So for example, if we have hypothyroidism, we don't have enough thyroid hormone. If we have hyporesponsiveness, this is a good example of this is our type 2 diabetes. We may have enough insulin initially, but we basically have the receptor and target cells that are not sensitive to attaching on that insulin and allowing that door to be opened and the sugar to go in. So that is considered insulin resistance again, and that's the basis of type 2 diabetes that we'll be getting to. So hyposecretion, hypofunction, or the hyporesponsiveness, and then it can be the hypersecretion, so excessive supply of the hormone. So if we have excessive cortisol and adrenocorticoid hormone, we have Cushing's syndrome. If we have excessive thyroid, we have hyperthyroidism or Graves' disease. Inflammation, tumors, those are other things that certainly could affect the endocrine, especially if you think back to the picture that we just saw. I want you to make sense of if we have any brain tumors, brain trauma, anything like that, that's affecting the hypothalamus and the pituitary gland. And those are our main communicators, and the pituitary gland is our master gland that affects all of the other stimulating hormones and how much hormones are going to be made and released by the subsequent glands. So a lot of our causes when we get into different endocrine disorders, a lot of them are brain and head type issues. So diabetes is just absolutely a disorder that you need to know really well. I put it right up there with congestive heart failure, chronic kidney disease, COPD. You know, it's just one of those things that we see often. There's a high incidence. We have a lot of hospitalized patients that may be in for a diabetic complication, or they might be in for something different, and we still are caring for their diabetes along with their other acute illness or injury. So it is a metabolic disease, of course. It's characterized by elevated glucose, which you already know, hyperglycemia, and also we would expect to see urine, glucose in the urine, or glycosuria. Remember, we do not want to, normally we shouldn't have protein, glucose, or ketones in the urine. Those were the three things that, you know, when we looked at a UA that we wanted to just right away check to make sure that they were not present. I also mentioned in the renal section that if a patient's blood sugar is consistently running greater than 200, that's kind of the threshold in which it can't really filter all of that. And so consistent blood sugar greater than 200, we will definitely see the glucose spilling in the urine and see that urine testing positive for glucose. So we know then that they're running over 200 consistently. Diabetes can result from either a defect in insulin secretion, insulin action, or both. So certainly insulin deficiency with type 1 diabetes, the beta cells, it's an autoimmune disorder, and the beta cells are not producing insulin. So there's an absolute insulin deficiency, which is the physiology of type 1 diabetes. Type 2 diabetes is more the insulin action, that it's not able to work as well, that the receptor sites are not as sensitive, and we call that the insulin resistance. And over time, in addition to the insulin resistance, the beta cells do get tired out, and they initially produce more insulin to accommodate, and then they get tired out and produce less. So type 2 diabetes is primarily insulin resistance initially, but they can also go into lacking insulin or not having as much as they need. It is chronic disorder, of course, of carbohydrate, fat, and protein metabolism, and we know that there are many serious complications with chronic hyperglycemia. So we will talk about them in more detail, but we really want to take good care of managing our blood sugars in our patients so that they can delay and prevent some of these very significant complications from occurring. So this slide is just showing some of the statistics on diabetes. There are lots and lots of statistics of interest, but I just wanted you to be able to look at them. You can see the significance and higher risk of strokes, heart disease, and cardiovascular deaths. We also, just expect, that high blood pressure, high cholesterol. It's happening in 73% of adults with diabetes. We also know that it is the leading cause of blindness, 25 times more common to have blindness if you have diabetes, so that's very significant. It's also the leading cause of renal failure in those patients on hemodialysis, so we see a lot of diabetic patients that will end up with end-stage renal disease and the need to be on dialysis if that is what they choose. It is also the leading cause of non-traumatic lower limb amputations, so anything that's not traumatic as a direct result of the peripheral vascular disease and decreased blood perfusion and tissue perfusion, and a reason for amputation of toes, feet, legs, etc. This slide is specifically talking about diabetes in the Native American population. We know that there is a significant increase in diabetes with patients of that ethnicity, so 2.3 times higher likelihood of a diagnosis with diabetes than a non-Hispanic white person. So we definitely target our community education and all of these things with this particular group. otherwise it does show you exactly too that, 1 in 3 individuals have prediabetes. So, 9 out of 10 don't even know they have prediabetes. So this is very, very staggering statistics, and we'll show you a picture here in a little bit about how all of these complications are starting to already formulate before a patient even knows that they have diabetes. So the sooner we can identify risk factors, the sooner we can get on board with treating those risk factors, less the medical cause, less risk of death and other complications. So the role of glucose. We know that our body needs continuous supply of glucose or sugar. We need that to fuel our cellular metabolism. So we need glucose in order to survive and to be living. So we have circulating glucose in our bloodstream that is then taken in by the cells and used as fuel for that cellular metabolism that we're talking about, especially the brain. And then we also store glucose in the liver, and this is called glycogen. That stored glucose in the liver is called glycogen. Another important point is just to understand that glucose is primarily provided by ingested carbohydrates. So carbohydrates are not the bad guy, but it is important for us to do carb counting and watch carbs if we are diabetic, because 100% of that carbohydrate is going to convert to glucose in the bloodstream. So 100% of carbs convert to glucose, whereas only 50% of proteins, for example, convert to glucose in the bloodstream. So that's one really important factor that in our education piece. The 2 key hormones that you need to know for regulating blood glucose, of course, are insulin. Insulin is going to lower the blood glucose. Insulin is released by the beta cells of the pancreas, and then glucagon is going to raise a person's blood sugar, that glucagon, if it's released, and it'll be released by the alpha cells of the pancreas. These next several slides are really important to understand the role of insulin. So again, insulin is a hormone produced by the beta cells of the pancreas. It basically binds to the receptors on the cells. It's a very specific lock and key, and that unlocks the door so that glucose can enter the cell and be used as fuel and be used for energy and cellular metabolism. So we not only need the insulin production, but we also need that sensitivity on the receptor sites, that insulin receptor, to basically be sensitive to be able to hook on that insulin. So that's why it is not just about the amount of insulin we have, but as we see in type 2 diabetes and with patients that are overweight, they develop that insulin resistance, and even though they may have enough insulin initially, they don't have receptor sites that are working and are sensitive to hook that insulin on in order to open that door. So understanding more about insulin is important, just how the normal functioning pancreas would work. We know that insulin is continuously released by the pancreas, which we call our basal or non-prandial, non-food, non-meal level. You don't have to remember how much per hour is being released at a basal rate, but it's important to understand that we do always produce a basal amount of insulin. So even if I am NPO and not eating, my body is producing a basal amount of insulin. Of course, higher amounts or bolus amounts are going to be released when we have an elevated blood glucose. When blood sugar is greater than 100, we're going to have more of a bolus being released, which again will be more mimicked with mealtime. When we are eating and when our blood sugar goes up, we have these little surges of extra insulin or boluses that are released to help bring that back down to normal. So we have our prandial or mealtime secretion, which we call the bolus. So again, this slide is really important to understand how insulin actually works to decrease blood glucose. It works basically in 5 ways. The first one is talking about transporting and metabolizing glucose for energy. So what this one is really referring to is that lock and key, that picture that we saw a few slides ago, that we actually have insulin available to hook onto that receptor and open the door and let the blood glucose into the cell. That's the first way that we're doing a lot of, that's an initial very important way that insulin is reducing blood sugar. Insulin will also stimulate the storage of glucose. Remember, we said extra insulin is going to be stored in the liver in the form of glycogen. So number 1, lock and key. Number 2 bullet is storage of glucose in the liver in the form of glycogen. Number 3 talks about one other way that insulin reduces blood sugar is that it decreases the liver's release of the stored glucose. So it is going to decrease the liver release of glucose, which then will in turn lower the blood sugar. Glucose can also be stored in muscle and adipose, which is basically our 4th and 5th bullet. So again, insulin is not just lowering glucose by the lock and key method. It's either lock and key, store it in the liver, decrease the liver release of it, store it in the muscle, store it in the adipose. So those are the 5 main ways that we are reducing blood sugar, or how insulin is reducing the blood sugar. The opposite hormone of insulin is glucagon. Glucagon is going to be released when we have a low blood sugar. It's going to increase blood glucose. So glucagon is produced by the alpha cells of the pancreas and will be released in response to low levels of blood glucose. So we will expect that glucagon to bind to receptors on the liver cells, stimulate the liver to break down glycogen, and release more of that stored blood sugar. There are several nice pictures coming up that just kind of show how exercise and eating, how all of this works. If we start at the top right where it says pancreatic beta cells release insulin, that insulin again is there's uptake of that by the adipose cells that will then lower the blood sugar. We know that if we've exercised and now our blood sugar is too low, that the alpha cells then could secrete glucagon in order to tell the liver to release some of that stored and increase the blood sugar. And there's just kind of this cycle, this mechanism and this feedback on whether we're high or low, whether it's insulin or glucagon that are going to be released. And students still get this confused, and I'm not sure why. We know that when we give insulin, we're giving it for high blood sugars. So insulin will lower blood sugar and glucagon will raise blood sugar, but it still never fails that some students will get that backwards. I love this picture. It kind of mimics a couple slides ago when we said what were the 5 ways that insulin will lower blood sugar. So it's showing you insulin at the very top, that it can store, liver will store the glucose, it'll store it in the muscle, will store in the adipose, and that will try to bring that blood glucose down to normal. It shows if we have low blood glucose, okay, now the pancreas is going to release glucagon, and glucagon then will tell the liver and adipose to release some of that stored blood sugar. So, and then it also goes on the top left, if we have high blood glucose, like after a meal, well then the pancreas will produce more insulin, and then of course the insulin will do what we just said, store it in the lock and key, store it in the blood, or in the liver rather, store it in the muscle, store it in the fat. So this is a nice visual for those of you that like to see it this way. This is an excellent 4-minute, 40-second YouTube on diabetes made simple and the pathophysiology. I encourage you, these are all active links in the PowerPoint. If you are playing the slideshow, you can click on that and view. This slide is just a visual depiction of what happens during stress. So I wanted to, mention that there's other things besides the liver and the pancreas releasing glucagon that are going to raise the blood sugar. So stress hormones, epinephrine, norepinephrine, cortisol, growth hormone, those are all things that are helping, that are released in response to a low blood sugar. So those are all things that are going to have the end result of that bottom right corner, which is the increased blood sugar. So if you can kind of follow that left path, we have the pancreas releases glucagon. Of course, that's secreted right away by the alpha cells. Again, signals the liver to basically stimulate the release of that stored glucose, which we call glycogen, and that's showing you how that alone is going to increase the blood sugar. But the other one that like on this picture is just remembering that cortisone, epinephrine, those are stress hormones that are being released, and those are going to promote catabolism or breakdown of any of those stored fuels to meet the needs that are needed right now, and therefore will also increase blood sugar. We'll obviously be talking about when patients are on glucocorticoids, they're on steroids. I mean, we know one of the main side effects that is high blood sugar, and that kind of coincides with this normal stress response that we just are talking about. So the correct answer here is B. Of course, the glucagon is what's going to be stimulated when we are not eating. So between meals, when our blood sugar is more likely to be lower, the glucagon is going to be released in order to release some of that stored glucose or glycogen from the liver. Since I'm not intaking carbs and protein and food sources that will convert to glucose, it's going to tell the liver to release some while I'm not eating. So the pathophysiology of type 1 diabetes is listed here. Again, there's several differentiators, and we'll be going through many slides that kind of talk about the difference between type 1 and type 2. We know that type 1 is usually diagnosed at 30 years or younger. These patients are typically not obese. They don't have insulin resistance. It's more of an abrupt onset. They many times present very sick to the emergency department in diabetic ketoacidosis, which is how they learn that they have type 1 diabetes. They are most definitely insulin dependent because there is an absolute insulin deficiency. And they think that this is mostly caused by an autoimmune process where there is self-destruction of the beta cells of the pancreas. So besides the insulin deficiency, basically the pathophysiology, talks about that the body is unable to inhibit glucogenolysis and gluconeogenesis. So there's going to be a fasting hyperglycemia, elevated blood glucose, even when not ingesting food. So they can't stop that breakdown and release of sugars from the liver, from the muscles, from the fat. That's what it's talking about. Glucose from the ingestion of food cannot enter the cells or be stored in the liver. Basically, it all stays in the bloodstream because we don't have insulin. We don't have that ability to attach to the receptor site and do that whole lock and key. So we have hyperglycemia, all of that staying in the bloodstream instead of getting to the cells and tissue where it is needed. A big differentiation between type 1 then is that because the cells are starved of glucose and energy sources and fuel, the cells are unable to obtain energy. They will then move to fat breakdown, and fat breakdown byproduct are ketone bodies. So fat breakdown is going to result in the production of ketone bodies, which then we will see ketones in the urine, ketonuria, and a resultant metabolic acidosis. We'll talk a lot more about this with diabetic ketoacidosis. And the last bullet is just reminding you that the kidneys cannot reabsorb all of the filtered glucose. If we're exceeding 200 for a blood sugar consistently, we will see that glucose being spilled in the urine. This is my drawing that I made for you just to kind of run through another way to look at it. So the normal is at the top. We see the little rectangles that are the glucose from the food. We see the bloodstream, and then we have our cells, and we have the little circles that's mimicking that insulin attaching to the cell, opening the door, and then letting the glucose go into the cell. So the glucose enters the cells to be used for energy. So this is normal function with a normal functioning pancreas. Diabetes mellitus is then, that's kind of it starting in the middle there. It's just showing you that you have all this glucose in the bloodstream, you have hyperglycemia, you have a cell sitting there that isn't able to get any glucose to that for energy sources. So the first line of defense, because that of the energy starved cells, is glucogenolysis. This is where the liver, any of the stored glucose that is stored in the muscle and liver in the form of glycogen will be released. So the liver is going to release all the glucose that it can, all of this glycogen, which will then further increase the blood sugar, right? So it's releasing this glucose, thinking that it's helping, but we still don't have any insulin. We don't have the insulin to be to help with the lock and key to get it to where it needs to go. So we'll further increase our blood sugar. Polyphagia, I have the symptoms here so you can understand why the 3 Ps, polyphagia, polyuria, polydipsia, apply to diabetes. Polyphagia is the patient feels hungry as the glycogen stores are depleted. So as all of the glucose stores are used up by the liver and released, and now we have none, the patient is going to feel very hungry. They're also hungry because the cells are completely starved of nutrition and energy source. The next thing that's going to happen once all of that, the liver is going to try to release all the stored glycogen. Patient's going to have polyphagia, going to be very hungry. So then the next line of defense is going to be, well, I guess let's try breaking down some fat. So the body will break down the fats. Again, that byproduct of fat breakdown is a fatty acid, and that fatty acid will result in ketone bodies or ketosis. So the ketone bodies are going to be broken down, or excuse me, the fatty acids or the fats are going to be broken down and form these ketone bodies. So this is where we're going to have ketones present, and this is where our body is going to become acidic, and we're going to go into that acidosis. So ketones are acidic. So again, now we're breaking down fat for energy, but we still aren't able to get any energy sources into that cell because we lack insulin. The thing that I have to the right of that second line of defense is just reminding you that the body now is going to try to rid acids. So we have these ketones, these fatty acids, and these ketone byproducts that contain acid. And so you can see Kussmaul's respirations, right? That deep, rapid respiratory rate that is trying to blow off CO2, which is acid. Patients also are going to get very sick. So this is kind of what we're going to see with diabetic ketoacidosis. They can have a nausea and significant vomiting. Again, remember, if we vomit stomach contents contain acid. So that's another way that the body is just kind of subconsciously reacting to this acidic state or acidosis. So a couple of those things just kind of tying it together. Third line of defense, what ends up happening is because glucose is a very large molecule, the glucose increases osmotic pressure and basically starts, because it's very hypertonic then, pulls fluid from the cells. So we end up with severe cellular dehydration. We have significant osmotic diuresis, polyuria, and with that polyuria and severe osmotic diuresis, we have polydipsia or thirst. So I'm hoping this picture makes sense for kind of how things are going to happen when we don't have glucose for an energy source, and we can also see how the signs and symptoms coincide with the disease and the physiology that's actually happening. This is just yet another way to show it, very similar to what we just talked about, where you start with the lack of insulin, you go off to the right, it talks about fat breakdown, fatty acids, ketone bodies, acidosis. Again, you'll see the increased respiratory rate, the Kussmaul's respirations, nausea, vomiting. You kind of see all of that ketoacidosis on that right column. On the left side, you see more of the increased production of the glucose by the liver. If we lack insulin, again, the liver is trying to release any and all of that stored glucose, which further increases the blood sugar, and we still don't have any way to get that into the cell. So that osmotic pressure increases. The large molecule of the glucose has a pulling power to pull water with it, which is why we'll end up with the osmotic diuresis, severe dehydration, severe loss of electrolytes, increased thirst, and not to mention the acidosis. So type 2 diabetes is, of course, very different than type 1. Type 2 diabetes is mostly initially due to insulin resistance and the lack of receptor sites that are available and receptive to having that insulin connect on and actually open the door, lock and key, etc., and get the sugar to the cell where it needs to be. So what you will have over time is you'll have progressive decline of the beta cell function. Initially, you'll have hypersecretion. The beta cells are just going to put out more insulin because it sees that there's hyperglycemia, so I'll just make more. Well, but then the insulin isn't able to work. There's not good utilization of the insulin that that you have because of the insulin resistance and lack of receptor site sensitivity. So then what happens, the beta cells, they increase production, and pretty soon they get tired out, and then they actually go into a progressive decline or decrease in how much insulin is being produced. So even patients with type 2 diabetes over time could end up needing or requiring insulin. I mean, type 1 is absolutely require insulin. Life is indispensable without insulin. And type 2 diabetes will diet, exercise, oral meds. But again, if they get enough sensitivity and insulin resistance, where that the beta cells of the pancreas get tired out and start malfunctioning, they too may eventually need insulin. We're seeing more and more of that. This is by far the more common type of diabetes. 90 to 95% of our patients have type 2 diabetes. Usually a little bit more later in life that we have diagnosis of this, although we are seeing it younger and younger with kind of problematic sedentary lifestyles, obesity, and things that are happening in younger ages for people, so that even by their mid-20s to early 30s, they already have type 2 diabetes and insulin resistance as a result of kind of that childhood and adolescent obesity increase. Oh, one other thing about type 2 diabetes that is very different is that there's always going to be enough insulin. There's always going to be some small amount of insulin to prevent the body from breaking down fats for energy source. So with type 1, we saw that fat breakdown in ketone bodies was going to happen. Type 2 diabetes will never get to that point, so we won't see the acidosis with type 2 diabetes, and we won't see them breaking down fat for energy source. This particular slide just shows you how we can end up with hyperglycemia. So we can have impaired insulin secretion in the top left. So if we have the pancreas that slows down on how much insulin is being produced, well, obviously they can end up with a high blood sugar because that insulin isn't enough to lower it. We also know that GI absorption of glucose, there's major source of glucose are absorbed in ingested food in the GI tract. We also can see bottom left, you see the liver, so increased hepatic glucose production. This just means if we have increased amount of how much the liver is releasing that stored glucose, well, that obviously can result in hyperglycemia. So sometimes there's just a lack of function of that mechanism for the liver to stop releasing the stored sugar. And then, of course, decreased insulin stimulated glucose uptake by the muscle. So decreased insulin to move glucose from the blood into the muscle will result in hyperglycemia as well. So this slide is just showing you how we come to a diagnosis of diabetes. We have our normals there. Fasting blood sugar is really what they're going to do. You don't have to worry about memorizing the numbers for random, but for fasting you need to know. Less than 100 on a fasting would be no diabetes. If you're in that 100 to 125, that will be the onset of insulin resistance and what we call pre-diabetes. And then greater than 126 fasting, and they'll have that on 2 occasions, would be diabetes. So again, we know that the normal blood sugar is 70 to 110, but if we're going off of fasting for diagnosis, you have the numbers here for you. I already mentioned here that there's sort of an epidemic with childhood and adolescent obesity, so they're really trying to get screening done better in schools, identify at-risk populations, Native American population, and just persons that are already heading down the overweight arena, because that's how we're developing that insulin resistance primarily. So screening children with a BMI, they're running greater than 85 percentile, let's say on their well child visits, where they chart your height and weight. We want to really pay attention to those young people and see if we can't get a better handle on their glucose regulation, their blood pressure, even looking at their cholesterol and things like that, and weight early on. It's kind of tough because they're building self-esteem, and we have to do it in a way that isn't totally crushing them, but we need to help them with better dietary and activity choices to hopefully prevent this just really a large increase in a younger age group with diabetes.